Well, my disclosure says Janssen Oncology. I'm actually not going to be talking about any Janssen products. So my talk is on androgen deprivation therapy for recurrent prostate cancer, intermittent or continuous. And what I'm going to do is I'm going to review the rationale for intermittent androgen deprivation therapy that was developed, summarize the results of the phase 3 clinical trials that compared continuous versus intermittent treatment, and then come to some conclusions for our clinical practice and what I do when I see patients in this situation. So much of the preclinical rationale for intermittent therapy can actually be attributed to the work of Nick Bruchowski, who's from my institution. Back in 1990, he was actually talking about cancer stem cells. And so he used the Shionogi tumor model, which is actually a mouse mammary tumor, which is androgen dependent, and actually mimics the human condition. It has androgen dependent growth, and at castration regresses, and then eventually comes back castration resistant or androgen independent. And with a series of studies, he demonstrated that the stem cells within the tumors expanded, and that it was an adaptive process, that these cells being exposed to the lack of androgens actually adapted to that and became androgen independent. And he hypothesized that by re-exposing these cells to androgens that he would allow them to remain androgen dependent. And indeed in the Shionogi tumor model, so here's the control, tumors grow, regress, and then regrow in a castration resistant fashion, but by re-exposing the tumors to androgens and then withdrawing the androgens with castration, you could cycle the tumors and keep them androgen sensitive for a longer period of time. He also showed in the same paper that you could do this in humans, and of course there's been a number of phase 2 studies that have subsequently showed that you can do this in, and cycle patients through multiple cycles of interrupted therapy, giving patients holidays from treatment. And that's where the other rationale for doing intermittent therapy came in. By giving that holiday treatment, holiday from treatment, perhaps we can decrease some of the overall side effects that we get from hormone therapy. So we do know that hormone therapy improves survival, delays progression. You heard Paul talk about some of all the benefits. There's also the psychological benefit of getting active treatment, watching your PSA go down. But of course, androgen deprivation therapy is a double-edged sword. There's also the expense, the early effects or the bothersome effects of hot flushes, libido, cognition, and mood effects. But there's also the later effects, decreased muscle mass, osteoporosis, lipid profile changes, and cardiovascular risk. And so by providing this treatment holiday, we could perhaps reduce treatment-related side effects, expenses, but still provide the benefit of immediate hormone therapy. And these side effects may not be so benign either in terms of just being bothersome. So if we, from the ASCO practice guidelines back in 2007, there was a systematic review looking at early androgen deprivation therapy, and indeed there was a decrease, 17%, in the relative risk for prostate cancer-specific mortality. But this was completely balanced by an increase in relative risk for non-prostate cancer-specific mortality, and therefore no overall survival advantage for immediate institution of hormone therapy, and therefore the panel could not make a strong recommendation for early ADT initiation. So there have been some trials or some data from the phase 2 work and the cohort data showing that by doing intermittent therapy there can be recovery from some of these side effects. And from, this is from Spry et al. And during the 9-month duration of androgen deprivation, there's a change in patient-reported outcomes and symptoms. For example, here we can see hot flashes dramatically increase as testosterone is suppressed. But then during the recovery phase, there's a slow improvement in some of these symptoms and overall global quality of life. Now, testosterone does not rebound immediately. In fact, here it takes quite a while, about 6 months after stopping the androgen deprivation therapy, before you start seeing things come back down to baseline. So there is some time that is required for that testosterone recovery and that benefit. Also, for the long-term adverse events from hormone therapy, there is some evidence that we can prevent this. And this is from Tia Hagano's institution showing effects on bone. Now, normally we would expect after initiation of androgen deprivation therapy quite a large drop in bone mass. But here in these patients, after several cycles, and getting bone density evaluations, you don't actually see this drop in bone mass, so suggesting that these long-term effects could be mitigated by providing treatment holidays. So the proof is in the pudding, and we have to look at trials from phase 3, or data from phase 3 trials. And actually, over the last 10 years, there's been a number of them. We've heard recently in the last 2 years the biggest of these, but I don't think we should forget about all the other studies that have been done, and certainly recognize that there's been a lot of efforts to look at this. But now these trials, though, they are all very quite heterogeneous. We have patient populations from 68 patients all the way up to 1,500 patients. And also, they're very heterogeneous in terms of the types of patients that were enrolled, both locally advanced, rising PSA, or metastatic. And some of these trials were very mixed, including both groups of patients who have very different prognoses. Primary endpoints were also very different. Overall survival in terms of non-inferior for the largest of these two trials, but a lot of the other trials were time to progression for primary endpoints and powered for superiority. Now, there has been a meta-analysis and systematic review that was just recently published and is now in hard copy, and I would draw your attention to that, which gives a quantified analysis of the outcome. But if you can look at the primary result, here on this last column, I can give you a qualitative answer in that really there has been no difference seen between these two, between continuous therapy and intermittent therapy. So in a sense, there's been no superiority of intermittent therapy over continuous therapy. So despite our excitement about the preclinical data suggesting that it may improve outcomes, that has not come to bear. But what about the other aspects in terms of quality of life and giving these treatment holidays? Well, and to inform our practice, I was going to just review these biggest 4 studies and take a look at those results with you now. So the first of the biggest studies to publish was the South European Uro-Oncological Group. This was 626 patients that were randomized. Now, there's more patients enrolled, but we only do the interrupted therapy on patients that actually respond to the treatment. But 626 were randomized to either continuous treatment versus intermittent. About 2/3 did not have metastases, 30% did have metastases. The primary endpoint was time to progression, and it was a superiority endpoint. The intermittent therapy was with cyproterone acetate, a steroidal antiandrogen, and LHRH agonist. And it was only for 3 months. So this is different from some of the other studies. But as you see, all the studies used a different duration of intermittent therapy. Patients would stop if their PSA was less than 4, if it was a greater than 80% decrease, restart PSA when it was greater than 10, or depending on what their symptoms were and depending what the nadir was. Again, you'll see that all these studies use somewhat different starting and stopping rules. For the primary endpoint, time to progression superiority, there was no difference. This is the survival curve, and you could see that, really that's right on top of each other. But interesting to note, though, that there was a few more cancer deaths in the intermittent arm, and this was balanced by a few less deaths from cardiovascular disease. This is a theme that we'll look at a little bit later. And then if we kind of take a look at the subsets, if we take a look at the M1 strata, so patients with metastatic disease, the intermittent therapy arm seemed to do a little bit better than the continuous therapy arm. Now, this was underpowered. The p-value is 0.157, so this is not statistically significant. The next study is the FIN prostate study. 554 patients were randomized. About half had no metastases, the other half had metastases. Primary endpoint, again, was time to progression superiority. Here, the intermittent therapy was cyproterone acetate, but it was just used for flare, and LHRH agonist was given for 24 weeks, so it's now 6 months of treatment, double the length of time. And a little bit of a different stopping rule as well. And you can see for all the curves, progression-free survival, death or all-cause survival, prostate cancer-specific survival, and treatment failure survival, the lines are really on top of each other, and there's no statistical difference. Although if you want to read the tea leaves, I can probably fit a laser pointer in between some of these curves and suggest maybe there's a little trend for intermittent therapy. But definitely these were superiority trials, so they are negative trials. So what really will give us some of the answers of looking at some of the non-inferiority studies. And the first to report out for non-inferior studies there was the Canadian-led study, although this was an international study with participation from SWOG, RTOG, CTSU, and the UK ICR. There was 1,386 patients randomized. These patients were all M0, meaning they had no metastases. They were patients with PSA relapse after prior radiotherapy. They could have had radical prostatectomy, but also received radiotherapy. The primary endpoint was overall survival, and it was a non-inferiority design. And they were looking for an upper boundary for the hazard ratio of less than 1.25. So as long as the 95% confidence interval was less than 1.25, it would be considered non-inferior. Now here the hormone therapy is now a little longer, 8 months instead of the 3 and 6 months we saw before. Non-steroidal anti-androgen was given for flare, not cyprodenone acetate. And the rules were relatively simple: stop if the PSA was less than 4, restart when PSA was greater than 10. And if you look at the survival curve, right on top of each other, although there's a little bit of splitting out at the end, but that's a tail on the curve. And the median overall survival is 9.1 years for continuous therapy, 8.8 years for intermittent therapy, hazard ratio 1.03, so right close to 1, and the 95% confidence interval was 1.22, so less than the hazard ratio 1.25. P-value for non-inferiority, statistically significant at 0.009. So as per the statistical design of the study, intermittent therapy was non-inferior to continuous therapy. Now there was an unplanned subset analysis that was actually retrospective. Gleason score wasn't collected. They actually went back and looked at this. And this is from the supplementary material from the publication. If you look at the Gleason score, if it was a low Gleason score or Gleason score 7, there was no difference. But if you looked at Gleason score 8, there was also no difference. The hazard ratio was 1.23, and the 95% confidence interval went from 0.83 to 1.81. So not statistically significant, but a little bit of spread in the curves. And again, reading the tea leaves, suggesting that perhaps this higher risk population with a higher Gleason score may not have done as well with intermittent therapy. But another thing about the death, if we look at what were the causes of death, in terms of prostate cancer, it was a little bit higher in the intermittent therapy arm, 41%, versus 34% in the continuous therapy arm. Again, not statistically significant, but looking at what were the other causes of death, this was completely balanced. There was actually fewer causes of death from other causes, 28%, and higher in the continuous therapy arm, 36%. Kind of similar to that SEUG study where we're seeing a balance of prostate cancer death versus other causes of death. But also the total number of causes of death were higher compared to versus prostate cancer specific death. Quality of life was better on the intermittent therapy arm as expected. Although the quality of life assessments were not timed to treatment, you can tell a lot in that first cycle. And indeed, there was benefits in terms of physical function, fatigue, urinary problems, hot flushes, libido, and erectile function. Finally, drug use. Patients were on about a third less of the time than on the continuous therapy. So on average, they got about 15 months of hormone therapy versus 45 months on the continuous therapy arm. The other trial I'm going to discuss is the SWOG 9946. Again, another non-inferiority trial. 1,500 patients randomized. This time, all the patients are metastatic. Primary endpoint was overall survival. Here, for the non-inferior, the upper boundary had to be less than 1.20, so a little bit more stringent than the PR7 trial, the M0 trial. Here, there was only 7 months of hormone therapy. Again, a different regimen. And stop if PSA was less than 4, restart when the PSA was greater than 20, but also it could be at baseline if the PSA was less than 20, but also at investigator discretion. So there's a bit of wiggle room there. Now here at the curves, you can see that in terms of continuous therapy, 5.8 years versus 5.1 years. So there is a numerical difference, hazard ratio 1.10, and you can get the pointer in there. But if you look at the confidence intervals, the 1.23 exceeds the 1.20, so it fails the test for non-inferiority. So it's not non-inferior. But does that mean it's inferior? Does the double negative mean it's inferior? Well, not really, because the lower confidence interval was less than 1. And so if it's less than 1, you cannot rule out superiority of IAD. And therefore, by the rules of consort and what the traditional statistical interpretation of this from Piaggio et al., this would be statistically inconclusive. Yes, there's a trend, hazard ratio 1.10, but it is a trend and it's statistically inconclusive for non-inferiority. So there was a various subsets analysis done, and one of them was that, perhaps patients with minimal disease kind of did better with continuous therapy, and patients with extensive disease kind of did okay with intermittent therapy, very similar to continuous therapy. However, this is somewhat counterintuitive. We would have actually expected minimal disease patients to kind of do better on intermittent therapy than continuous therapy, but this could just be a matter of the way minimal disease and extensive disease was defined based on where the bone mets were, whether it was axial or peripheral. Quality of life was a co-primary endpoint, and the primary comparison was done at 3 months after randomization. And it was better for impotence, mental health, and libido. Now, the problem with this is, I showed you earlier that usually testosterone recovery is not so good until about 6 months. So at this point, at 3 months after stopping the hormone therapy, it's a little bit unsure of how many patients were having a recovered testosterone at that time. And this could be somewhat a placebo effect, knowing that they had stopped the treatment. However, it's difficult to know without those testosterone levels. However, at 9 and 15 months, there was trends for better quality of life in several domains, but this did not meet predefined significance level. Drug use was also less. Time on drug therapy was about 50%. So summary of the data. What can we say about intermittent ADT? For time to progression overall survival, despite the preclinical promise, it is not better for progression or overall survival. From a large trial, we can say it's statistically non-inferior for patients with M0 disease, but for patients with M1 disease, it's not statistically worse nor non-inferior, so it's inconclusive, but there is a trend for worse overall survival. There's definitely less drug use, therefore decreased expense, potential for recovery from side effects for patients, and quality of life is better. What are the unanswered questions? Well, what is the best schedule? Is there a better schedule that could be used? There's different durations. Could we use a lower PSA cutoff? Could we change from the time we stop or start? But we have to remember, although giving more overall therapy, or this may mitigate your survival concerns, but it would also decrease the candidates for intermittent therapy and the benefits of intermittent therapy on quality of life and toxicity. Which patients are best suited or not for a trial of intermittent therapy? And unfortunately, at this time, with the data we have, we cannot confidently use Gleason score, extent of disease, nadir of PSA, and so on. We can all have our gut feelings about which patients may be candidates, but right now, we don't have any data. We can't practice precision medicine. So what do I do? So for patients that don't have metastases, that are initially responding to therapy, intermittent therapy is an option. Overall survival is non-inferior, there's improved quality of life, and patients are on treatment a third of the time. However, I think we should always be considering deferred treatment first. The risk of death from other causes is higher than prostate cancer causes in an unselected patient population. And therefore, before starting hormone therapy, I think we need to be careful whether we really need to start hormone therapy in that individual or not. For patients with metastatic disease, the data is somewhat inconclusive. There's an improved quality of life. Duration for medical castration is less. But in practice, I still offer intermittent therapy. But I do discuss the pros and cons. There are quality of life benefits. There's risks, and you can decrease the risk of long-term therapy. But there is this trend to worse overall survival. Therefore, I do very close follow-up, and I reinitiate therapy liberally. Thanks very much.